I'd just like to welcome Rebecca Martin here from the Marsden in the UK. Welcome, Rebecca, and welcome to ANZUP 2023. So I was just looking at I just was in the meeting with your presentation on female sexual dysfunction or sexual dysfunction after bladder cancer surgery. As a clinician, what do you find is been the biggest barrier, or what do you find is the biggest barrier in dealing with this sort of topic with patients and clinicians?
Well, firstly, thank you very much for having me at ANZUP. I mean, what a great conference and great lineup, and fantastic to be in Australia and hear all the wonderful things that you're doing. I think the key sort of take-home message from my presentation for me was about actually just opening up the conversation with patients, and I was delighted to kind of have a platform to talk about consequences of cancer in the plenary session, and really fantastic that as an organisation you kind of recognise the importance of not just treating the cancer but treating the whole person, and I think when it comes to sexual function for men and women, it's about asking the right question at the right time. And there's a lot, and I think what we were talking about this morning in the breakfast as well, it's, there's not necessarily one right time to ask that question. Actually needs change over time. There are some obvious times to ask or talk about sexual function in bladder cancer. And, the obvious one is cystectomy. Where the surgery itself, has a direct impact on the sexual organs, and, counselling patients about that is fundamental. For me, the question came to me in terms of my area of research, actually from a patient story. And I was really struck, obviously in my clinical practice I see women who are out the other side of cystectomy, for instance, and are living with the consequences of that surgery. And so I have an understanding of it, but actually coming back to the sort of why I chose this area of research to sort of unpack as a clinician researcher, actually it was a patient story. It was a 28-year-old lady. For the very first time, she was talking at a small conference, a nursing conference, about her cystectomy. For the very first time, she was talking about how that had impacted her, sexually and intimately, and her personal relationships. And I was really kind of struck by her experience, or her retelling of it, that actually she didn't feel like she'd been fully counselled about that before her surgery, and she hadn't really anticipated her sort of post-surgery needs, and so it's through those kind of patient stories that actually I realised through my clinical practice that there was a lot that we weren't getting right, so I sort of started to delve into the literature, and I realised that actually perhaps the experience that as a clinician I was having in my work was actually perhaps translated across other people's practice too, not just in the UK, but actually I started to realise that this was a global phenomenon. So I thought, well, let's look at this, and actually, our sort of initial systematic review kind of tells us that actually, we're not even asking patients those questions, and why aren't we asking? Why aren't we finding out what's important to them?
So, do you think that like in your literature review that you, what did you find was sort of that barrier for clinicians in actually approaching that question?
I think we're very sort of heavily into the sort of biomedical model of care, which is completely understandable, and I think it's, a safe area for clinicians. You've got a physical problem and you've got a biomedical solution. And I think when it comes to penile rehab, it fits very neatly into that model. That said, obviously there are clearly, psychosexual dysfunction is not just physical, it's actually psychological. So there's, when you sort of fit it into a biomedical model, you're missing a whole proportion of actually the patient experience. But I think for women, the biomedical model is less clear. So if you're kind of looking for a solution when you're asking a question, so you're already sort of preempting an answer, it's less available to you. I don't. I mean, from what I've read, I think patients are often waiting for clinicians to ask that question and for it to be a legitimate question. When we're very much focused on, cancer outcome and some functional outcomes, I guess, when you're talking cystectomy and other treatment pathways. I think to a patient, perhaps, when the primary question is, or the primary consultation is, your cancer clear or otherwise, then it's kind of doesn't feel like a legitimate question to ask in that consultation from a patient perspective. But the literature tells us that's what the patient is looking for. And from a clinician's perspective, if you're looking at functional outcomes, then it feels like, because it's a very intimate, personal topic, it doesn't feel like safe, territory to fall upon. So I think, the clinicians are waiting for the patient to bring it up. And, I think I termed it in my talk as the intimacy mismatch. Patient is waiting for the clinician to broach it, and the clinician is waiting for the patient to broach it. And so the questions just don't get asked.
And I think, you touched on something that I think is very true and very passionate with nurses, is that we're there for our patients. And when it's a patient experience that you're sort of looking to try and find a better solution for them or a solution for them, I think, I must, commend you on your work that you're doing, because there is a gap in the literature in regards to sexuality, and particularly female sexuality. So all the best and congratulations. And thank you for coming.
Thank you for having me.